Hello and thanks for joining me as I go deeper into the understanding of the human body and see some of the bits that we don't often get to see. My name is Julian Baker and I've been working on people and teaching bodywork and human dissection for over 20 years. And over that time, I've often struggled to equate what I'm seeing and feeling with what the anatomy books describe. In the last couple of sessions, I've been relating this feeling to that of my original occupation, which was as a chef. The process of being able to feel changes while you're cooking, sort of feeling things change, knowing when to stop, and developing an almost intuitive feel about what complements what and goes with what, made stepping into working on people quite a natural progression for me. So thank you so much for all your comments that you've sent me on the previous sessions, and the questions and some of the ideas that you've been posing, and the feedback I've got. It's just it's blown me away to see and hear how much of what I'm saying really makes sense to you. It's like I'm not alone. The other thing that struck me was the breadth of disciplines that have been reaching out to comment, and it shows me really clearly that any of the material I'm talking about and presenting is really important and relevant to, I'm going to say, pretty much anyone who's working on or with the human form. So whether that's manual therapists, movement therapists, even personal trainers, they all come under that sort of banner of health and fitness professionals. But they're a category that I refer to them to you people as transformational engineers, if you like. So this is the community of those who are in the business of helping the people in the process of transformation. Whether it be helping people to get fitter or stronger, or moving from pain and dysfunction in whatever form it takes with, whatever age person you're working with. So if this is you, then, and you were involved in the process of transformation, and everything that I say here is aimed at you, at us, it's our field. And I'm going to say that it isn't going to be stuff that you're likely to find anywhere else. Now, and don't get me wrong, I mean, I've learned from some incredible anatomists, trainers, body workers, and so forth, and I still do. But for me, there isn't much out there that sort of encompasses all the disciplines presented by someone from within the same community, that brings all that sort of body anatomy together. And the thing is that I'm pretty sure that whether you're an experienced therapist, been doing it for years, or whether you're just starting out, you see and feel and maybe even sense changes with your clients that sometimes just don't make sense, and sometimes can't easily be explained. And I'm going to guess that you come up against this regularly, maybe every day, and perhaps you've got questions that no book is going to answer. And I know how you feel, and that was what was my experience. That was where I was. For me, the challenge was to allow myself to believe in what I was doing, the trust that what I was doing wasn't, sort of wrong or unethical. I wasn't sort of doing it like I was supposed to, and trying to drag meaning out from what I was doing and feeling and seeing and experiencing was tortuous for me, and took me in so many circles and different directions, and sometimes maybe questioned my own sanity sometimes about whether what I was experiencing was real or not. The question, who am I not to say that X, Y, or Z is correct when it's not supported in the books? It felt presumptuous or arrogant, and it took a while for me to trust myself and my work and my approach, and let the results speak for themselves. But even with that, I still wanted to understand more about what was going on. I just wanted to sort of intellectually grasp it. For me also, when I started out, I was worried about not knowing the names of all the structures I was working on and how they worked and what they were doing, and I felt stupid, I felt unqualified, and because I didn't know all the details that were in that book, and by the way, I still don't. So, but the thing is, guess what? These names aren't real. They are, what I mean is we don't come out of the womb with all these names stamped all over us, tattooed on us. When you open somebody up, they're not there. The names are all man-made. I mean, literally made by men, and they're made or given for a reason or a purpose, and sometimes they're self-explanatory, but they are a means to an end, and presumably to make things easier or simpler, because before there was all numbers. And of course, it's good to have a common reference for us all, but whether it's simpler or not remains to be seen. We just take it for granted that that's what it is. The question though is this: if you didn't know any of the names of the structures in the body, would it change what you feel when you felt it? Would it change the way that you work or the approach to your discipline? And I think sometimes the thing that we think is going to help us, the anatomy book, is almost the common enemy. If you've ever done something with a client because you felt it rather than thought it, then this is the community for you, where your experience and your intuition ride tandem with your knowledge. And I'm here to sort of try and join them up further for you and bring them together and sort of make sense of things if I possibly can. And I so wish that I had been given this information a long time ago, and that someone had shown me or reassured me, if you like, that what I was doing wasn't out of step with anatomy or wrong or left field. It's just that it didn't fall into a set explainable shape. Anyway, like I said, it took me for a while to get to a point where I could create a bank of knowledge and explanations, and I know that it's going to be valid for everyone when I talk to them, and anybody that's working in that sort of transformational engineering business, health and fitness, it's going to fit in for you. With all the interest in what I've been doing, so many questions, I'm going to put together something formal, and the first time, I've not done this before, and so I'll be launching this sort of program really soon, so look out for that. But for this session, what I wanted to do was join up a little bit about what we've been looking through and over for the last couple of videos. We've looked at how the superficial and fatty layer, the fat cells, are held in place by collagen fibers, and these blend from the underside of the skin down to the deeper fascia and become that tissue that we know as the deep fascia. So please go back and have a look at those if you haven't seen them. The collagen fibers that we refer to are incredibly strong, and we can see that restrictions, scarring, and injury in this area can result in lack of movement elsewhere, quite a long way sometimes away from the original injury. So in this session, what I want to do is I want to look at one particular area that is massively complex, which I feel for me personally is the starting point for whatever imbalance gets presented, and where we really need the balance between stability and mobility in joint amounts is really important. So I refer to this area as the biomechanical fuse box for the human body. And it's where most of the major muscles will join up and then will reach to and join up dozens of other interfaces. So if you think of it like a major railway hub or the spaghetti junction of the body, if you like, and it massively loaded, busy parts going under, over it, through it, and it can get clogged, it can get breakdowns on it, or what have you. And this is the area that is referred to in a very broad sense as the thoracolumbar fascia. Now I'll break fascia down into much more detail into coming sessions, but for now it's really important to remember that we can't change fascia to any great degree with our hands or anything else for that matter. So you're going to break it before you change it. It's primarily a scaffold for the body, and it allows muscle, bone, and other structures to sort of be held in place. It's a container, and it allows us to be stable and functional. There's all kinds of stuff talked about fascia, and lots of it I'm here to tell you is pretty implausible. But this one particular type of fascia has a myriad of different directions and blends in it, and across the lumbar spine, wrapping around the muscles, and all the muscles of the back, by the way, and acts as an attachment point for the gluteus muscles, some of the structures of the upper back, and for a lot of abdominal tissues as well. So it has three distinct layers: posterior, middle, and anterior, with the anterior layer having tissues that sort of join up and go up as far as the psoas and the deeper muscles of the lumbar and thoracic spine. There's some discussion about the cellular nature of that, but I'm not going to get into that. When we think of the abdomen, we often refer to the front part of the body. We go, this is the abdomen, and we think of those planes anatomically differently as well, and we call things anterior, posterior, and so forth. And the trouble is that there isn't really an all-encompassing term for wrapping, except I suppose for wrapping. So the same thing goes for when we talk about something being in front of or behind something else. So our need for defining language and the language itself often creates definition, but then it's hard to create flexibility around that you've got a definition and we tend to stick to it. So tissues that travel in a lot of directions will also be very similarly hard to define anatomically, and we tend to sort of scrape them away and make things simpler. And so where things have a lot of depth, our visual way of seeing things combined with that difficulty around language can I think sometimes leave quite a big gap in how we effectively describe and understand things. So as muscles such as, say, the gluteus maximus, for example, will have origins and insertions, but the depth and complexity of the fibers that make it up, as well as the how widely it attaches, is going to be lost to some degree in the translation and the explanation of it. And also lost will be how other fibers blend into it and into each other. And although we can talk about a word which is decussation, I'll put a definition of that up as well. It's our tendency to make boundaries, and it makes therefore one structure defined as being separate from another, and that's really what I want to try and overcome. But the thoracolumbar fascia is one of those structures that defy any attempt to really define it, and so anything that you're likely to read is always going to stop short fully of explaining this myriad of directions and tensions that exist, and even a tiny portion of it. So close to the spinous processes, it becomes almost bone-like in its presentation. It's really hard, and we can still see that the fibers reach across to the opposite side. There's still directional travel. And trying to follow those lines of strain along one fiber, we'll see it dive down into the body of the fascia and be lost, and only for another directional fiber to take its place. It's one of those sort of, is it Escher, the ever-raising circle? If we try and slice away at the sheets or the layers of the thoracolumbar fascia, we just don't see a clear definition. And again, the sheets tend to overlap and dive in and out of each other. If you understand the loading that takes place in this, in and through this area, then the weaving and double backing and distribution is understandable. And this is the area of the body of maximum force and loading, as well as an area that also needs to be able to move, it needs to flex, it needs to respond to movement, and all the things that we're asking it to do and perform. The spine, as we can understand, isn't straight, but consists of a series of alternating curves from top to bottom, with these sort of primary and secondary curves creating that sort of in and out shape that's so familiar of the spine. Now, as it moves upwards, the spine gets thinner, and this is going to reflect the need for more mobility around the shoulders and neck. But conversely, the lumbar spine is in the middle of, we call this the trunk, and we understand that this is, the trunk extends to the lumbar spine too, and it's thick and wide, and the vertebrae are bigger and more solid than the structures in the upper neck. So we need that sort of solidity. So as well as needing to be strong and stable, the lumbar spine also has to take on a role of absorbing the loads that we place on it from, both above and below. Our head, for example, it has to carry our viscera, quite a load in some instances. And in women, it's going to be the site of pregnancy carrying. And also, don't forget, amongst in it all, we still have to have movement. So the biggest problem for this area that I see is that it's already pretty well loaded with connective tissues, which is a potential problem. It needs to be hydrated for connective tissues to move, and the best way to hydrate them is movement. So the main enemy of the thoracolumbar fascia is going to be sitting. Mechanotransduction is a term, is a process that describes how cells get activated and start producing stuff when they get signal, they get loaded. So sitting is a loading action for the lower back. So imagine all that upper body weight pushing down on the lower back with your butt muscles having to sort of contract and be stable to support it. On top of that, the strong, thickened fascia of the lumbar area is dealing with keeping things tense. We need tension so that we're not falling off our chairs while we're sitting. So the human body is really happy to adapt according to the demands placed on it, and it's why we're so successful as humans. It's called plasticity. We can turn things on or off and change to our environment. We can turn the feeling of being full off. And keep eating to store energy or not eat. And we can live in cold places or hot places, and we can adapt pretty quickly and pretty easily to our external environments. Not so long ago, we would have squatted to move our bowels, and now we use a toilet. And this adaptation and this changeover might not seem hugely dramatic, but it means that we're not now doing something with our bodies that we would have been doing every day, and there will be consequences. And I talk about that in other sessions. So this is especially the case if we replace one action with another, such as sitting. Now that sounds like an inaction, but even sitting needs to have structures that are going to allow us to do it and which will adapt. And will adapt especially if we do something repeatedly over a long period of time. By the way, I'm not now suggesting that we all go and poo in the woods. I'm just saying that adaptability means that we, when we change one action, we adapt to the action that replaces it, and that this involves mechanical and chemical processes in our bodies that are going to facilitate this change. So this process is enormously cool, but also potentially difficult to overcome because we're not always fully aware of it, of what's going on. The adaptation isn't judging you. It's not doing, like your mother, it's not doing what's best for you. It assumes that you know that. It's just going to adapt to whatever you tell it to do, and whatever it is you're training for, whether it's to become an Olympic weightlifter or to sit down and watch box sets of The Sopranos, then your body is engaged in the process of giving you the tools to do either of those. So the visual images, as I mentioned before, of the thoracolumbar fascia tend to be tricky to illustrate clearly what's going on, the breadth and connectivity of the tissue around this area. And as a result, it tends not to get thought of or considered as a starting point or focus in treatments or assessment where, I really think perhaps it should be. From a practical perspective, we can understand that this thoracolumbar fascia isn't just the tissue that is being delineated by our anatomy books, but actually is a structure and a tissue that is going to be blending into the abdominal. So the external oblique is going to be very, very much a back structure, and the thoracolumbar fascia is going to be part of this. It's going to be encasing it. When we look at tissues like latissimus dorsi is blending seamlessly. Trying to dissect latissimus dorsi out from thoracolumbar fascia becomes very confusing in terms of trying to work out where it begins and where it ends. And the same thing goes for serratus posterior inferior is blending into this as well. If we come a little bit further down, excuse me while I show you a bit of bottom, this is the posterior iliac spine, the PSIS down around into here, where the beginning of the sacrum is. So this thickened thoracolumbar fascial tissue isn't going to reveal much in the way of muscle for quite some time, and we can have a little look at this in a dissection. We sort of scrape away looking for muscle, looking for the deep, erector spines that we find in here, and it really isn't there. So quite often when we get into this tissue, what we'll find is that the variation of thickness as it comes around the crest of the ilium is quite marked. So if we have somebody that's in flexion, lateral flexion through the side, particularly as a result of pain, we can identify that the overlap of the thoracolumbar fascia, where it's coming down onto the gluteus medius, which we'll talk about in a second, is quite marked. So thoracolumbar fascia is encasing the erector spinae structures, the iliocostalis, the longissimus, and the spinalis, and traveling, pretty much a long way up the spine to meet the trapezius. But as it gets towards this end, it starts to become a little thinner to allow for mobility or mobilization to take place. So we've got this really strong trunk. Tense that back up a little bit. We start to move latissimus dorsi. What we'll start to see is we'll start to see fibers of that reaching across into the glute on the opposite side. So the directions, the multiple directions when you look at this are quite marked. Once we get through the skin and the superficial fascia, the muscle pushes back onto the fascia, and it becomes hardened and tight, and the differentiation of the muscles is just not there. So relax it, let it go, and we'll just move latissimus dorsi again. Okay, we can't really move latissimus dorsi without engaging into the lower back. And we'll bring the arm back down to the side again. All right, so trying to find a specific direction is almost impossible. You're not going to ever be able to establish clearly what the direction of your thoracolumbar fascia is going to do, but it is going to be influenced quite strongly by function and movement and the way that somebody has held themselves, the sport they've done, the job that they've done for many years. There are 3 layers to the thoracolumbar fascia: the posterior, the middle, and the anterior. And the transverse abdominis is going to be part of that middle layer, and the anterior layer is going to be seeing the psoas and the quadratus lumborum involved in this tissue. Deep to this, we also have the iliolumbar ligament. So coming from the ilium, going to the transverse process of L5, sort of deep into here, is a strong ligament that's the attachment site for QL, the quadratus lumborum. And again, it's deep under this, and it's encased around the back with the thoracolumbar fascia. So you're not going to get anywhere near that, even though it's sort of quite a long way out here. You're not really going to get anywhere near QL to be able to do anything with it. The question always comes, well, can we change anything? And as far as thoracolumbar fascia is concerned, well, you don't really want to. You don't want to be changing fascia in a way that it's going to, fascia could change to any great degree, then it wouldn't be doing the tensile, strong job that it is doing. And you'd end up sort of, falling over. Further down, as we come across from the crest of the ilium, we see the beginning of gluteus medius. Now, gluteus maximus is deep under this this adipose layer. Now, we don't really know why we have fatty tissue around our buttocks. It's just something that we have. But even with somebody that's quite toned, just trying to let that go if you can, Jun, thank you. Even though somebody that's quite toned, as with Jun, you still see there's a covering, which there should be. And the gluteus maximus, deep to this, doesn't have the same degree of deep fascia that the gluteus medius does. So as we overlap it and we blend into it, we'll find that gluteus medius has a really strong attachment site of the superficial fascia into it. Now, I'm fascinated by what this might mean, but certainly functionally we're seeing that there is a fibrous element of the gluteus medius and the adipose tissue that goes around it, but when we get to gluteus maximus, we don't have that sheety covering like we have on the gluteus medius. Gluteus maximus is going to get really fibrous when it comes up to the edge of the sacrum here. So where the edge of the sacrum and the edge of the pelvis come together, you're going to see fibers, huge fibrous connection as that glute max blends itself across into the fibers of the glute max on the other side. So we have to think of gluteus maximus as being a sling structure, a structure that is going to straddle this sacrum and held in place and really referencing as far as the thoracolumbar fascia is concerned. If we go further down and we start to get to the coccyx, then again the coccyx is going to be involved in the supporting nature of the pelvic floor. So all the muscles of the pelvic floor attach either completely or in part to the coccyx, so your pubococcygeus, puboanalis. So tensional laydown in this area is going to draw and pull and influence coccyx and therefore pelvic floor. So we can start to look at reproductive elements in relation to thoracolumbar fascia through pelvic floor. Similarly, as far as our viscera is concerned, as far as our blood supply to the lower leg, You can't quite see the nature and how much of a curve that we have of the lumbar spine, but the anterior curve, that forward curve, also brings the blood supply. The iliac artery bifurcates, and the iliac vein comes back up, and so this is all under pressure as it's coming, sort of dropping off that lumbar spine, L4 and 5, and again massively influenced by the pressure that's going to be put upon it through the thoracolumbar fascia. So there we go. I mean, as far as treatment approaches is concerned, it's less about what we're going to do and more about where we're going to start from my perspective. And this, to me, is the biomechanical fuse box of the body, and we'll have a little look at some of the way that some of those fibers distribute themselves in and around this area, and just bearing in mind that as I said, the things that we call the front and the back aren't really the front and the back. We have to have a line at which we say, this is anterior, posterior, superior, and so forth. But generally speaking, these are encompassing tissues. The obliques are as much on the back as they are on the front, and the transverse abdominis comes all the way around. So it's quite an important structure. The pressure and tension of the thoracolumbar fascia as it's laid down through this area is going to hugely influence hips, both in sort of lateral movement, sort of up and down, but also in rotation. So again, you can see if I just move that through here, we just see how much rotational movement is going on here. So upper body rotational movement, really important to make sure that we can to get this trunk moved as well. That's where we're pulling this. So the enemy of this is sitting. When we sit for too long, this is going to get thickened, it's going to get harder, and tissue is going to start to move less, and as a result we're going to start to bend less and not getting on the floor and so on and so forth, and so this again gets stiffer and harder and becomes more painful. So that's a bit of an overview of thoracolumbar fascia and how we are considering it. And once you get this idea of this X-ray vision, and this is what has been really powerful for me over the years, is the ability to see when I'm putting my hands on somebody, it's not just coming from the idea of an anatomy book. I'm not thinking muscles here, I'm thinking directly what I'm touching, what's the relationship of what I'm touching to the next thing down and the next thing down, the next thing down, and then how are those tissues then joining up. So it's changed my mental imagery enormously, meaning that all the movements that I see anybody make can be joined up, and I can understand them, and I can effectively then assess body-wide movement, as well as then decide what I'm going to do therapeutically or ask my client to do. And again, if they are going to be referred to anybody else, such as a trainer or a movement therapist, or they're doing anything else, then I can really work on helping those people to develop their techniques. So it's a really interesting way of X-ray vision of getting into the body in a way that is just, I would never have believed possible. So there we go. I think a lot of therapists struggle with where to start when they're presented with lots of issues going on with clients, and I think it's hard to really get across this complexity and the depth of this area. I think I hope you've managed to get some kind of idea as to how important this fuse box this is. Listen, thanks so much for the feedback. It's been amazing to see how much you're really relating to what I'm trying to get across, and the impact that it's been having not just on you transformation engineers out there, but how you think about your clients as well, and your comments have been just incredible, so thank you. In my next video I'm going to be sharing how to go even deeper into this way of thinking, and I'm sort of joining things up and helping to get some kind of X-ray vision that I talked about, and I'm going to be opening a registration to what I'm calling my Transformational Anatomy Program, TAP. I love an acronym, and this was kind of accidental but fitting, because it's asking you to tap into what's already there under your hands and transform it into a new way of thinking. So in this program, I'm going to be taking on a number of manual movement therapists who are really ready to get deeper into the human form and understanding the connections. And I'm going to limit it for space so I can personally work with people on the program. So the registration is only going to be open for a few days. So if you are ready to move forwards and lift the veil on some incredible information and imagery, then I can't wait to share the details with you. So look out for the next video.